you very much, WL. I'm glad to be here. Thanks for inviting me.
So I'm assuming that you were born in South Africa. You went to college there.
Yes, Cape
That
Town.
was also,
In Cape Town.
in Jamestown.
Cape Town, South
Oh, Cape
Africa.
Town. Okay. And then how long have you been in Canada?
I arrived in 1996.
19. So you've been as we would say a Canuck for quite a while.
That's quite a while, right?
Okay. So tell me, how did you uh, make the transition from a family doctor to what you are doing today?
Okay, so right from the start of my career, I was in family practice. And for some reason, when we were in a group practice, I had patients from other physicians whom they were very happy with come and see me often for counseling problems. And I couldn't work this out because it was not something I particularly wanted to do. I had my own patients, and um, I ended up doing quite a lot of it. The reason eventually came out, I was told by some patients, this is in South Africa where people are more, let's just say, direct when they speak to one. They said, "You've got the face that says, 'Tell me about it,'" which was confusing at the time.
I'm sorry, Dr. Campbell, can you say that again? What did they say?
They say, "We come to you because you've got the face that says, 'Tell me about it.'"
I see.
So I couldn't make sense of that. I thought, well, okay, if that's what they think, and I did see them, but I've always had an interest in the counseling aspect of medicine. Now, of course, it's naive to think you can be a family physician without counseling. But when I came to Canada, I became quite exposed to more chronic pain patients. And these are complex cases because there's a lot going on. And I started dealing more and more with them. And I did well, I think, mainly because I had this experience, the counseling experience. So I joined what's called a multidisciplinary pain management program that consists of physicians, psychologists, and over a 6 to 8 week period, we treat people with chronic pain. And then I did other aspects of chronic pain management, and then I ended up writing a book.
Okay. Now, can I um, make a little comment here? Uh,
Sure,
to take the time to actually talk to the patient
right,
is kind of out of sync with medicine today, where everything is a rush. You've got to bring them in.
correct.
You know,
Absolutely. No, that was always the challenge. We have to remember that we deal very poorly in Western societies with chronic conditions. We do well if you have a surgical condition, trauma, acute disorders, which means sudden onset disorders like pneumonia and that, but we don't do well with chronic pain. And one of the main reasons is that in the current medical model, the consultation time is too short to achieve much.
right.
That's one of the big problems. Yes.
Okay. Now, when you talk about an issue where maybe surgery is going to be necessary, how many times do you think that uh, uh, planned surgery had its uh, genesis in something else going on in the individual's life that could be dealt with the counseling?
Well, I think counseling is very much directed at ways of living, lifestyle, diet, exercise, even work. We now know that work is healthy for one. It's integrative function, brain function, and so forth. And that's any job, um, almost any job. So basically, we can, I believe, prevent or delay many chronic diseases by paying attention early on to lifestyle. And where counseling comes in, it's no good giving someone a shopping list, lose weight, do more walking, do this, do that. There has to be a motivational aspect. Now, physicians are often uncomfortable with it. They say, well, I'm not a psychologist. No, we're not psychologists. We're not sociologists, but we are forced Because we are dealing with human beings to look at very carefully at their psychological makeup, we do have some training in it, as well as their social circumstances. There's huge determinants of illness. So what I like about the counseling is you can motivate a person and get results more quickly.
Okay. Now, what about what we think? Um, how much of our attitude is involved in our health as opposed to uh, diet and exercise?
Well, a great deal. As the way we think about our bodies and even the way we think about illness, the way we worry about having something, that is one of the factors that falls in the realm of epigenetics, the non-genetic factors that determine our health or disease states. So it's very encompassing, and that's why pain management has traditionally not been well treated. It's very expensive, it's very time consuming, and basically what you have to do is you have to look at all the factors and everything in their lives that are increasing their pain level. In fact, the development of pain has a lot to do with thinking patterns, chronic pain I'm talking about here, not bumping your arm and having acute or sudden onset pain. A lot of that has got to do with one's focus. And I explain in the book that people who are hyper focused on the pain when they first injure the body part are people who are more likely to go onto chronic pain, developing chronic pain. It's all explained in the book. So even our thoughts, they say be careful what you want, be careful what you focus on. Because when we were learning how to drive, the person who taught us to drive said, look, don't look at the accident on the side of the road, don't rubberneck. You go where you're looking. The same applies. It's just a metaphor. It's the same applies in health and in life in general. You look at people who have expertise in anything, sport, music, the arts, business, they all focus. The same with our health. What are we focusing on? Are we focusing on a good, healthy lifestyle that gives us a good chance or not?
Okay. Let me throw in the name of your book here just so I don't forget. The book is The Language of Pain. Fast forward your recovery to stop hurting.
That's right. Yes.
Okay,
So
so it may take time, Dr. Campbell, but don't you think the patient uh, appreciates that time that you spend?
oh, they do. They do. Even just getting their story out in one session. When I was in the pain program, I had at least an hour and a half with them at the first visit. So they tell you the whole story, and they tell you afterwards that they've never really had the opportunity of conveying so much information. That's the catharsis. We talk about catharsis, feeling better after confiding in another person, even though they don't always have the expectation you're going to be able to do something about everything they bring up. So that is very important. They feel heard. Now the problem comes of explaining them, or the issue rather, it's not a problem, it needn't be a problem, of explaining what is chronic pain. Most of the people I saw did not have a good idea that chronic pain was a disorder or disease in its own right. It was not merely the persistence of symptoms of pain. So much research from Southern Australia, I believe, um, showed that just explaining what chronic pain is to a lot of people already lowered their pain levels without any further intervention. Why? Because they didn't feel sort of out of control. They didn't feel somehow they had bad luck. The word pain itself comes from the Latin poena, which means punishment. Some people feel guilty that they've been punished for things. It's the stories you hear are astonishing. So then we explain the nature of pain and why this is more difficult than maybe other people who've had the same operation or injury. Then we show them the psychological and social factors that have caused the pain and are the main drivers of continued pain.
Can you give me an example of somebody with chronic pain? Are we talking about migraine headache or some other type of pain?
Okay. Migraine headaches you can use a lot of the migraine headaches as a specific pathology, which has been well described in the field of neurology. So there's specific medication for it. But people who have a lot of attacks can still be helped by some of these principles that we teach people and train them. When I talk about chronic pain, I'm talking about either an injury, a surgery, or condition that's causing pain to persist, not typical for that kind of injury, operation, or condition. For example, you can get a football player that's had many injuries, and 1 year he has a knee injury, and for some reason, this injury does not improve as his previous injuries did, and there's no overt reason for it. But that will eventually take them out the game, and they may have pain in that area for years, daily, life intrusive pain.
All right, and then is chronic pain then, would you say, is one of the contributing factors to the opioid crisis that we're
Oh,
having?
yeah, yes, definitely. When I came from South Africa in 1996, I could not believe the patients that I inherited on opioids because it was not as big an issue there. Um, but the long-acting opioids were heavily marketed in North America in the mid 90s. It was sort of just treated till the pain disappears. We know this is not a good idea because one of the biggest tolerance problems with opioid prescriptions is that people develop tolerance. So, in order to get the same level of effect, you have to keep on increasing the dosage, which means that the risk to the patient increases, right? So that leads us to the biggest thing we fear of opioids is high dose can lead to respiratory arrest. They stop breathing, usually in their sleep, often in their sleep, and they die. So it's a slippery slope. You can never really win because the dosage has to go up. You can switch to another opioid and start lower, but eventually you have to ratchet it up. So that was the prescription of epidemic, what I call the prescription epidemic. Recent years from other continents, we've had an influx of illegal fentanyl. That's the street version. So there was a prescription crisis, and there was the illicit use crisis. So that's been largely reversed. I think in Canada, certainly, and the States as well. It's had a lot of publicity. A lot of people, many people have died, and it's tragic. The bottom line is how you know that chronic pain is a biobehavioral disease is that there is no effective medication for chronic pain, opioid or non-opioid. Even though we allow for chronic pain medication because the treatment of chronic pain should be multimodal, which means that it should include these psychosocial aspects as a must, but medication, injection therapy periodically, if you want acupuncture, go for it kind of thing. But the mainstay to try and reverse the cause of chronic pain. In medicine, we always try and remove the cause before we treat a condition, right? Like try and stop the person who's got lung disease from smoking. Try and stop the smoking while you give them drugs, because remove the cause. The only thing that really is likely to remove the cause and or drivers of chronic pain is the psychosocial interventions or treatments. And I can tell you it's not rocket science. It's quite a lot to manage, but it is very simple, and yet it's hardly provided at all. One of the issues is that physicians are poorly trained in university about chronic pain. I've lectured to them as residents, and it hasn't changed a great deal. The other thing is that, you know, they pain pain is not given such a high priority, it's hard to bill for the psychosocial treatments. They're also very expensive if it's done in the context of a multidisciplinary team. So all around, even though 25%, 20 to 25% in aging democracies suffer from chronic pain, it's kind of silent treatment.
Okay, so give me an example. Let's say let's say that I have a back problem, and I go in, I have surgery on it, and then
Yeah,
I don't recover from the pain.
right,
The pain continues. So my choice is to continue taking the painkillers. As I take those painkillers, I need a higher dose because my body gets accustomed to it, and that leads to more problems. So
right,
what are you going to do for me to get me off of those painkillers
right.
and relieve the pain?
Well, the first thing I'd do is I would explain to you where I think the situation is headed, not to a good place. And I would do my best to persuade you that the way forward is counterintuitive. It's not what you would expect. When something hurts, we tend to use it a lot less, right? You stub your toe, you walk very carefully, you watch out for it. But when it comes to an injury like you described, the cure lies in persisting with physical activity, getting on with your social life. Well, I mean, these are unusual times, so we're in a bit of a strange period, but
Yeah,
under normal circumstances, I'm
right.
speaking, if this were normal circumstances. Because now you people say, well, what's that got to do? I've got pain. You talk about social. It's your brain learning that things are fine and it doesn't keep it alarming you with more pain, which is what chronic pain actually does. I would advise some CBT sessions, cognitive behavioral sessions. These are found to be effective in a lot of disorders, anxiety, depression, sleep disorders, especially pain disorders. And it will show you how your thinking and your focus about it needs to change. Again, it's a hard sell because people say, come on, I've got pain. How's talk therapy going to help? The other thing is trying to relax as much about it as you can by doing things like meditation and so forth. The other alternative, if it's established, if it's become established, is to get into a multidisciplinary treatment. But these cost about $35,000 to $45,000 for 6 to 8 weeks. It's not within the
What
range
kind
of
of
most.
and can you explain that a little fuller? What is a multi?
Okay, so a multidisciplinary pain program looks at everything. So it's expensive because there's a lot of specialists, psychologists, occupational therapists, physios, physicians, and they have you usually in house for 6 to 8 weeks. There's all these lectures, daily tasks, getting you back into what you did before. We're trying to return the person to where they were before. And you see a huge transformation in 6 to 8 weeks, but then they leave and the habits fall apart. So you see an improvement in as little as 8 weeks, but the longer term follow up, if it exists at all, in my experience, most programs, they're not research programs, so they only follow up for 2 years. We don't know what happens to them long term. I've had patients that have done that, and I've seen them as private physicians. Then I have an idea of what goes on. But that is once the pain has been established as chronic pain. So I'm saying if you get the person early enough, the early advice is better.
Okay, so if I'm understanding you, uh,
Right.
the pain can be alleviated by my making changes in my lifestyle, or
Right.
at least getting back to what may have been a great lifestyle to begin with,
Right.
and I do that in my own mind.
Well, you get help with it, you get guidance, and they know what needs to be done and they coach you through that. But you get a lot of exercises to do at home and so forth. Yes, it's training under guidance. Now, the people say, well, how can these things help you? But pain is a sensation, even though it's unpleasant. It's still a sensation. And we sense things with our brain. I tell people, you don't see with your eyes and hear with your ears. They just transmit the impulses through specialized sensory cells to the brain where it's interpreted. For example, if you get a blow to the back of your head, you won't see a thing, even if your eyes are perfect, because that area of the brain's gone. We also know that with someone has an amputation of their arm, say, they still have pain in their hand where the injury was. That's phantom pain. So where's it coming from? You say, it's not coming from the hand. The hand's gone. Those circuits are in your spinal cord and brain.
Yeah.
And then there's the thing. It takes a bit of time to explain. If you want, I can explain the analogy of how chronic pain works and a faulty alarm system for a house security. If you like, can you explain that by saying that in a way, a metaphor for your brain is like the electrical wiring in a house. It can be faulty. So we know that with an alarm, it's supposed to warn us about a home invasion, a window broken, door breached, or something, some sort of intrusion. So when that happens, it warns us. We can then take action, go to our room, phone the cops, whatever. But when it becomes too sensitive, it becomes like a faulty alarm where a storm can set it off.
Right.
Or a raccoon walking past your front door. So you get this alarm all the time.
Or the battery runs out in the middle of the night and the alarm goes off. You're sound asleep, and all of a sudden the alarm goes off because the battery went dead.
Absolutely. So it's a case of you've got this nuisance value. You see, there is biological value in acute pain. Your brain's telling you if you don't take your hand off the stove, you may not have much of your fingers left. But in chronic pain, there's no biological value. It's not protective. The accident was already happened. It's now the brain being alarmed, not at the injury, but at how your life has shrunk. You're not seeing people because you feel you're no fun and you refuse invitations. You lie on the sofa if you've got severe pain, you're not moving. This is very distressing to the brain. So pain then becomes a repetitive, ongoing, faulty alarm system in the brain. Now, eventually, when you first tell that to people, they give you this look like, I don't know about that kind of thing. Right. And we're used to that because it is new to them. But it's a totally logical mechanism. We're reversing the changes over time. Now, the good news is what took a long time to develop will not take, if done well, will not take nearly as much time to reverse. I think every expert that I've heard speak, without exceptions, does not really believe that recovery can occur without these psychosocial concurrent treatments. And yet we see very little of it. Go to a pain program, or you might see a CBT counselor who does that in meditation and comes up with some aspects of biopsychosocial treatment.
Okay. Well, what about the people who are doing research into the subconscious mind and how to access the subconscious mind to make the changes there?
You mean like hypnosis and so forth, right?
Yes.
Okay, so I've traditionally not been overly involved in hypnosis, but certainly we know that the subconscious mind is all powerful. We carry memories from early childhood that still influence and infuse our decisions. And I would say, yes, there's work on a lot of fronts. We do also know that there's links with trauma. People who've suffered PTSD or severe abuse are more likely to develop chronic pain because that's that feeling of out of control, and then they focus, they ruminate. All of this is understandable. It's just not helpful. And it needs to be explained to them. Now, to try and transfer this information and these skills in a 15-minute consult where you don't have access to the person often, is it's difficult, really difficult. It's not happening.
I read one of your articles where you talked about four things that we need to get rid of in our lives, and one was bad relationships.
Yes. You know, when the so-called new happiness theory, it's not new, it goes back to Aristotle. It's also called positive psychology. The movement started in the 90s. There was a tremendous amount of work done on happiness theory. And it turned out that what makes people happy is surprisingly a few things, most of which deal with relationships. We are social people. How many languages are there in the world? And and then the psychologists will tell us that most of our, our communication is nonverbal. So we need people. However, the, if you merely think of someone and your pulse starts racing, this is a stressor in your life. How it is managed, sometimes it's tricky because it's close family, it could be parents or your child. But that conversation, I always advise them to have that conversation if appropriate. I mean, the child must be adult and the parent, no one must, they, they shouldn't have separate psychiatric problems, or you have to exercise caution in those cases and have the conversation what it is doing to the individual, what the relationship, why it has very few positive aspects. And there may come a time where even old friends, you say, look, I'm dealing with a lot, I'm getting pain treatment, and I just can't do the time right now. If they take it badly, I would suggest that the friendship was maybe not as deep as one suspected.
Okay.
But at the end of the day, eh, why do we have these relationships? For benefit, not selfishness, but for our well-being. And if it's doing the opposite over a long period or a significant period, one has to think about terminating it. And of course, this should be done with consideration and respect.
Okay. In a healthy relationship,
Right.
um, excuse me. Let's say I'm feeling some kind of pain, whatever it is, whether it's short term, long term.
Yeah.
Sometimes uh, just having my wife hold my hand does
Absolutely.
more for me than the pain medication that the doctor prescribed. Would you agree with that?
I would absolutely agree with it. When we started our psychiatric block, when we started, well, early lectures were on anxiety, and in the tutorial, the professor asked us all, what is the best, we weren't qualified yet, what is the best tranquilizer you know? And of course, we, through the common names that we knew about,
Right.
no, wrong, said another human, sympathetic, empathetic human being. Even you in another country, you don't understand their language, they're with you, they get what's happening, and they're there in the room, and you don't feel threatened. That's a tranquilizer.
So there's power in the human touch.
Without a doubt. Without a doubt. Um, yeah, no, it's always been the case. I mean, in literature, you see it in history, and
If we look at excuse me, if we look at the opposite side of that,
right,
in regard to a bad relationship, a negative relationship, a friend that hey, with friends like you, I don't. Who needs enemies?
right.
Can that be as detrimental to your health as a loving relationship can be positive for your health?
I've actually seen cases like that, and yeah, I would say that.
Okay, so how do I either change the relationship, um, or discontinue a relationship without just going out and saying, hey, I don't want to be around you anymore?
Are you talking in the context of people without chronic pain or with chronic pain?
No, well, it's I think from my perspective,
Yeah,
uh, if we're talking about relationship and the impact that it has on our lives, a bad relationship, I think,
Right.
can
Okay.
give you chronic pain if you're not
Right.
careful.
Right. I would say I would have the conversation. I would ask to speak with them. I'll tell you what I will do. I would invite the person. I said, look, I think we need to talk. Are you prepared to meet with me? There's something I'd like to discuss. And if they were agreeable, I would try and arrange a walk. I find if you don't bring it up right away and you walk, and it may be a very unusual suggestion to the particular person you're asking, but I find in any conflict situation, the worst thing is hunched up over coffee or tea or worse, alcohol, and people are ready to pounce. They're almost in pounce mode. When you're outdoors, it doesn't have to be in a theme, in a park or anything. But you're closer to nature and you're moving. I think people are more reasonable. I found that in my own personal life. And you can have those difficult conversations because there's movement and it's out in the open. I suppose a psychologist could tease this out more eloquently, way more eloquently than I can. And just say, look, I'm at the stage where I'm now done enough years to not want to have unfavorable time that I can possibly avoid. We don't seem to be hitting it off. We used to, but now we're not. Is there anything we can do? Because I would rather solve this than not, unless that's really not your field. Um, and I think people will often be open or say, well, you've changed since you became this high position, and I find you offish, and they say, then you can analyze it further. But I think if it's done respectfully, even if you don't get treated with respect, you can leave in good conscience. Then they'll separate themselves, and at least you're not carrying baggage. That's how I look at things. I've got to think of me in a few years' time. They may be here, they may be gone, I may have lost track of them anyway.
One of my favorite motivational speakers was Jim Rohn. He's since passed away, but I recall in some of his trainings, he used to say that a few good friends is better than a lot of, well, not so good friends.
Yes, absolutely. And people who've been a long way with you and are still with you. And there's a Spanish proverb, it rhymes in Spanish as well. I don't speak Spanish, but it's make new friends, keep the old. The one is silver, the other is gold. And then I've never forgotten that. I read that when I was about 12, and it just seemed, and I didn't have experience of long-term friendship at that age, of course. So I think that's good. It's people who know you, and our good friends, they not only know us, but sometimes in company, they remind us of who we are. Um, it's just the context, what they add to the conversation about their in-depth knowledge of us
Okay.
as
Do,
an observer.
well, Dr. Campbell, do you think that I will have less pain if I one have a good lifestyle as far as I'm eating healthy foods as opposed to burgers and French fries for every meal. I'm getting at least a moderate amount of exercise, and I'm not polluting my body with, for example, cigarette smoke or excessive alcohol use, those things. And then I develop good relationships with the people around me. Are those kinds of things, are I can do those things? Are they
Absolutely.
going to improve my health?
Without a doubt. I mean, substances like coffee, tea, I drink them. I drink some alcohol. These can agitate you. When you in an environment, a physiological environment, your body is in a state of fight or flight, high adrenaline, noradrenaline levels. That is not an environment in which you can really recover well from anything. That's why we recommend meditation, CBT, all these calming things. So try and cut out the caffeine. Try not to overeat. Balanced diet, very varied diet. Mediterranean diets, I always defer to that. I'm not a dietitian, but that's really stood the test of time. Um, so that can help a lot. And if you're on good terms, one of the one of the confounders of all chronic disease is being in a high state of worry, flight or fight. And that's why for years, I've been telling people that I'm going to fight this one. I said, don't fight your chronic pain. That's not an environment where you can heal. What about understanding what's going on with chronic pain, and we come up with a plan to outsmart, outwit, or trick the chronic pain.
Okay.
Don't waste your energy on something that we have to learn the language of pain. That's why gave it that title. So anything you can do that's calming and that makes you feel better. I've asked people, and this is a very difficult thing to ask me. I said, eventually, I'm hoping to persuade you that you will try not to focus on the pain, even though it's there, it's unpleasant, you can't ignore it, and focus on quality of life as well as functionality. You can now do something you couldn't do 3 months ago. Build on that. You drive where you're looking.
Yes.
And focus is whatever we focus on expands. Becoming brilliant at something requires focus. Um, so I that's the kernel. If you can going for a walk near a lake or something, that makes you feel better. You're enjoying life more. That will modulate your pain down. It's like a volume knob. You've got little circuits that are like volume knobs. They can ramp the pain you feel down, and they can ramp it up, like your friend that you don't no longer feel is a friend, that makes contact and is intrusive and gets you riled.
Well, Dr. Campbell, this has been a very, very intriguing conversation. I thank you for it. We're nearly out of time. Is there one final piece of advice you'd like to give to us in this day of COVID fear?
Yeah, I think that COVID's done a lot of things. It's focused. Firstly, it makes one realize that what we had wasn't so bad. Because the way people frame things. But at the moment, we're going through a period that we don't have a lot of experience with. I mean, how many people, are there's no one alive really with usable information from the last epidemic in the early 1900s. So it's mopping up a lot of the resources as it will, which I'm sure is the right thing to do. But one has to also be aware that things like chronic pain and all chronic diseases and other conditions that are maybe not being seen at hospital because the people who have them are afraid. I mean, there's various reasons, and it's completely different everywhere else in the world. We have to be mindful that something that we can do for ourselves is always there in chronic disease. There's a lot we can do for ourselves, not to say that must keep us from the hospital. And I often see people who've had chronic pain as long as 20, 30 years, and it's like, oh, this sounds like an uphill battle. And my one quote that I always go back to is from Art Buchwald. He was a journalist and he always had witty things. He said, whether it's the best of times or the worst of times, it's the only time we have.
Yes.
And I think that's what should motivate, rather than focus on, what confuses us or what scares us is how do we maximize what the circumstances are now? And I'm sure with an attitude like that, our perception of the time, it may shorten it. I can't guarantee it, but stay busy with what interests you, with what you value.
Dr. Campbell, thank you very much for being with us today. You've been watching Real Hope with W.L. Laney and my guest, Dr. Trevor Campbell. Dr. Campbell, again, thank you so much for being with us. And
Thank
you have a great day. Stay safe. And remember, with hope, anything is possible.
Right. Thank you very much for having